Hello and welcome to our first CHoSEN hospital profile. I'm Jillian Adams, the Director of Strategic Initiatives at Illuminate, and I'm really grateful to be joined today by Dr. Erica Wymore. Dr. Wymore is the Medical Director of the Newborn ICU at Lutheran Medical Center, as well as on faculty at the CU School of Medicine and a steering committee member of CHoSEN Quick. So thanks for being with us.
Thank you for having me.
Yeah.
Pleasure to be here.
Wonderful. So I hear that you and the Lutheran team are innovating around how you're using your EHR to support CHoSEN practice change, especially around breastfeeding. Can you tell us about the challenge that you identified?
Yes. So I think in some of our previous CHoSEN forums or meetings, we have talked a little bit about our breastfeeding rates among infants who are exposed to substances during pregnancy. And there's a lot of variability what we have found. Certainly, we have high breastfeeding rates across Colorado. However, amongst this particular population of mothers with substance use disorders, there's some variability that we noticed throughout our CHoSEN data by hospitals. And so we were focusing at Lutheran, as I'm the medical director there, but also just looking at our breastfeeding rates are sort of within the lower 5 hospitals across our CHoSEN collaborative. So we wondered if there was a way that we can improve our breastfeeding rates among this population. So we initially started with really defining what is an eligible breastfeeding mom. And that was really a challenge. We went back to our policies for Lutheran and wanted to make sure that our breastfeeding policies for all moms were in alignment with our breastfeeding policies for infants that were substance exposed, opioid exposed newborns. And what we found is that there was some discrepancy. So we went back through with our CHoSEN team and went through our two policies, compared them side by side, and really tried to make sure that at the very beginning for any infant who we were evaluating for breastfeeding, that we really identify the safety of breastfeeding. So that would be the first thing that we just tackled, was that our policies were not in alignment. So determining whether or not a baby was eligible was sometimes falling through the cracks. The second thing that we did was really try to process map who all is in contact with these moms and these infants when they're admitted for delivery hospitalization, and how do we determine breastfeeding safety and eligibility, because there's a difference between infants who are eligible to breastfeed and those who aren't in regards to those breastfeeding success rates. So we really wanted to say and answer our question at Lutheran specifically, among infants who are eligible to breastfeeding, what are our breastfeeding rates? And so we defined those as infants who are over 35 weeks gestational age, with opioid exposure, and mothers who are in a treatment program or under the care of a physician. And the next sort of sticking point for us, which has been a real challenge, and I think amongst a lot of other facilities too, is what do we do when moms are in a program or they're on methadone, but they have a history of relapse, or they've had some history of substance use of another kind, another substance, within a time frame before delivery, anywhere from 30, 60, or 90 days. And what's really challenging in addressing our policy is that the national guidelines don't provide a clear cutoff point to say you must be sober or under the, on your methadone without any relapses for 30 days or 60 days. And that's what's really challenging, is the Academy of Breastfeeding Medicine and the AAP have slightly different recommendations for that. So as a group, we're still challenged with trying to come to an agreement about what seems best. And right now, the great thing at Lutheran, which they do a wonderful job of, is they screen women for substance use in pregnancy at the time of their delivery hospitalization. And it's very consistent. And it's through the EPIC toolbox where the nurses do the triage screening and identify women early on in that delivery hospitalization for substance use. And if there is any concern, the mothers automatically have a urine toxicology test, as well as a cord toxicology test is ordered for the newborn. So that's one great tool that we have at Lutheran. So we wanted to expand on that using our electronic medical record. So what we found in our process mapping was that one of our challenges is going from, okay, moms have this identified trigger that they have a history of concerning substance use, and they're going to have a urinalysis, and then that trigger to the infant is automatically made. So how do we make sure that that goes through going from the maternal providers and nursing team to the infant providers and nursing team. So we have a handoff that is done verbally, but then also our next opportunity was to actually create a trigger or some sort of a notification within the electronic health record. So we use Epic at Lutheran, and one of our opportunities here after speaking with the Epic team and technicians was, could we develop something called a BPA, a best practices alert, which comes up on the infant's medical record anytime it is opened. If a cord toxicology test has been sent on the infant, it automatically pops up as a PPA to evaluate for safety of breastfeeding for that infant. I can keep going. I can keep going.
Yeah.
So just I can keep talking about the sort of the alert. I don't know if you want me to keep going or not.
Yeah, well, it definitely sounds like building from that, building from the strength of how you all are already using Epic to kind of optimize those workflows as well. I wonder kind of from that work and how you're really approaching addressing breastfeeding rates for eligible dyads. Kind of what lessons would you maybe share with other providers who are considering kind of a similar innovation around how they're using their electronic health record?
I think that our first order of business that we had to determine was to do a process map of really determining who all is in contact with this family. And that's not just the nurses and just the physicians in isolation that are making decisions, but it's so many other people, social work, as well as lactation consultants as well, and nurse practitioners caring for those babies. So once we develop that process map, which is something we do sometimes when we do site visits to different hospitals around a specific challenge or barrier that a site may be having, it's really helped me learn how to do this as well, to say, where is this, who's going to own this challenge? And what we found through that process was that we were really putting a lot of emphasis on our L&D nurses, and we really felt like we're placing an undue burden on them, when really majority of this all is happening post-delivery on the baby side. And how can we shift that responsibility off of our L&D team? Now, notwithstanding, we still want to make sure that we're providing a lot of education before babies are born and a lot of education before moms even come in for delivery. And that's a whole nother obstacle that CHoSEN is tackling as well. But I think that was really identifying who is the personnel that we really needed to target, and so that we can have them feel comfortable and give them the resources, as well as how do we improve the communication, because that's where the challenge happens. A baby is born in the middle of the night. How do we, ensure that we're evaluating the safety for breastfeeding, so we're not sending mixed messages to the family that, okay, well, at nighttime you might be eligible, but now we have the day team on and now we're not going to let you. And that's an erosion of trust that we don't want to contribute to. So we really want to make sure that we're all on the same team. So the first thing I would say is develop a process map, determine who are going to be your providers at the bedside. And when I say providers, that means everybody who's interacting with this family, and then consistency of that education, so that we're all trying to say the same things. So those are our goals right now. And it's a journey, because it takes time to implement these things.
Absolutely. If there are other CHoSEN sites out there that are interested in doing something similar, is there any kind of support that the CHoSEN Quick Steering Committee or kind of that team is able to offer?
Yeah. Well, I have to give immense kudos to Colleen Wheeler. She's on our steering committee as well, but she also happens to be my partner in crime at Lutheran as well. She's amazing and has done a lot of work when she was previously at Denver Health in working with their Epic systems and their Epic analysts to be able to develop products within the Epic EHR, whether they be the ESC screening tool embedded within the nursing flow sheets. And now we're working with the possibility of doing a BPA. Now, each hospital system, and certainly Lutheran is part of SCL Health, we can't just talk with our own Lutheran people. We have to make sure that we discuss this with the whole system as well. So that would be one piece. But I would say that I think Colleen has developed a depth of knowledge in how to navigate this and work with the Epic teams, who are very, very supportive and enthusiastic and want to improve the EHR so that it works better for all of us who are providing care to patients. So I would definitely think we can reach out and ask for that assistance and facilitation.
Wonderful. So again, if there are CHoSEN sites that are interested and want to learn more, please don't hesitate to reach out to anyone involved with supporting CHoSEN to get connected. And if folks want to learn more about the breastfeeding driver of CHoSEN, be sure to check out our relatively new provider education videos that are available on chosencollaborative.org. So with that, I'm going to thank you again, Dr. Wymore, for joining us and walking us through some of what you've been doing and learning at Lutheran.
Yeah, my pleasure. And I would also say, I realize there's great work happening all across the CHoSEN Collaborative. So if you have something that has worked well for you, please reach out to me, because I would love to hear about it, learn from you, and we're all going through this together in different ways. So I'm open to assistance and suggestions as well. Thank you so much.
Wonderful. And that might just end up as a future hospital profile on the website too. So great.
Great.
Thank you.
Thank you.